Hey everyone, welcome back to the channel. I'm Professor Shaibu Bello, and today we are going deep on the pharmacotherapy of type 1 diabetes. Think of this as your one-stop masterclass. Whether you are a medical student grinding for exams or a physician brushing up before clinic, I've got you. We go all the way from the biology of the disease to insulin dosing, the newest adjunct drugs, the technology that is genuinely changing lives, and how to handle the emergencies when they hit. Everything is built on the latest ADA and NICE guidance, so this is current, exam-ready, world-ready knowledge. Grab a coffee, hit subscribe, and let's get into it. Before we sprint off, here is the game plan, and I promise it builds logically. 6 modules. We start with foundations, how the disease actually happens. Then insulin pharmacology, the drugs, their kinetics, their action profiles. Module 3 is where it gets hands-on, dosing and regimens, the actual maths you will use on the ward. Then adjuncts and technology, pumps, sensors, exciting new agents. Module 5 locks down targets from ADA and NICE. And Module 6 is acute and chronic care, DKA, hypos, and long-term complications. By the end, you will explain insulin kinetics, calculate a starting regimen from scratch, and manage the emergencies with real confidence. Let's build this brick by brick. So what is actually going wrong here? Type 1 is an autoimmune demolition job. It starts with genetic risk, those HLA class 2 genes. Then something triggers the immune system. T cells go rogue and autoantibodies show up. Bit by bit your beta cells get destroyed until there is almost nothing left. And here is the line I want tattooed on your brain. This is absolute insulin deficiency. Insulin is not optional. It is life-sustaining. Skip it and you tip straight into ketoacidosis. One lovely detail, right after diagnosis, many patients get a honeymoon phase, a brief remission where leftover beta cells still work and insulin needs drop. Enjoy it, but warn them because it does not last. Here is something that surprises a lot of students. Type 1 does not begin the day symptoms appear. It is a stage disease we can actually see coming. Stage 1 and 2 or more islet autoantibodies, but normal glucose, completely presymptomatic. Stage 2 dose antibodies plus dysglycemia. Stage 3 is the clinical onset everyone recognizes. The antibodies to know are G65, IA2, ZNT8, and insulin autoantibodies. And here is the kicker, your risk climbs exponentially with each extra antibody. C-peptide is your window into residual beta cell function, and it is low or gone in established type 1. This staging is exactly why we now screen at-risk relatives, because we finally have a drug that can act back at stage 2. Hold that thought. Diagnosis time, and this is where people get burned. The classic type 1 patient is younger, lean, presents rapidly, maybe in DKA, antibody positive, C-peptide low. Type 2 is older, overweight, gradual. But watch out for LADA, latent autoimmune diabetes in adults, slow onset autoimmune diabetes that masquerades as type 2. Here is the clinical pearl, straight from NICE. Do not use age or BMI alone to rule type 1 in or out in adults. I have seen lean adults mislabeled as type 2, and it goes badly. Look for the clues: ketosis, rapid weight loss, a personal or family history of autoimmune disease. When in doubt, check the antibodies and the C-peptide. It costs little and changes everything. Let's talk mechanism, because this explains everything we do. Insulin binds its receptor, tyrosine kinase, and flips the whole body into storage mode. It drives glucose into muscle and fat through GOT4, builds glycogen, fat and protein, and slams the brakes on the liver's glucose output and on ketone production. Now look at this curve. A healthy pancreas gives a steady basal trickle all day with sharp bursts at every meal. That is the template. Everything in modern therapy, basal bolus pumps, closed loop, is just us trying to copy this exact picture with injections and algorithms. Keep this shape in your head, because it is the North Star for the entire dosing section coming up. Okay, the insulin toolbox. For families, rapid and ultra-rapid analogs, Lispro, aspargulazine, your mealtime cover. Short-acting regular insulin, the only one you can run intravenously, and the backbone of DK, drips, intermediate NPH, the older basal, and the long-acting analogs glargine, ditimir, digludec for smooth background cover. Now a few rules that save lives and save marks. Standard strength is U100, but watch for concentrated U200 and U500 forms. Only regular insulin goes 4. Basal analogs never go IV, and you never mix them with anything. And NPH is cloudy, so you must resuspend it before drawing up. Get these preparation rules rock solid, because they come up constantly. Let's zoom in on the rapid crew. The standard analogs, Lispro, aspart, glulisine, kick in within 5 to 15 minutes, peak under an hour and a half, and are gone in 3 to 5 hours. The ultra rapids, faster aspart and lamjev, are even quicker off the mark, and inhaled Afresa is faster still. Practical points: give these right before eating, within 15 minutes, and remember your highest hypo risk sits around that peak. The ultra rapid shave down the 1 and 2 hour post meal spikes, and they are the go-to inside pumps and closed loop systems. Just know that overall A1C and hypo rates land pretty similar to the standard analogs. The real win is in those post-meal numbers. Now the old guard, regular and NPH, and please do not dismiss them, because they still matter. Regular insulin, onset 30 to 60 minutes, so you dose it a good half hour before meals when it is subcutaneous. But its superpower is that it is the only insulin you can give intravenously, which makes it the backbone of DKA and HACE infusions. There is also a U500 form for severe insulin resistance. NPH is the intermediate, cloudy, needs resuspending, with a real peak at 4 to 12 hours that drives nocturnal hypos. It is the basis of twice daily premixed regimens, but honestly, peakless basal analogs have largely taken over. Know it, respect it, but reach for analogs when you can. These are the workhorses of modern basal cover. Glargine U100 gives flat, roughly 24-hour action with no real peak. Toujeo, the U300, is flatter still and lasts beyond a day. Datumir sits at 12 to 24 hours. And digludec, the ultra-long champion, runs beyond 40 hours, which means it forgives you if your dose timing wobbles day to day. Why do we love analogs over MPH? That flat, near peakless profile mimics natural basal secretion with far fewer nocturnal hypos. Keep an eye out once weekly icodec is on the horizon. And one admin note for the UK tour, Ditimir is being withdrawn. Expected end of 2026, so those patients will need switching. Small detail, but it will catch you out. I love this slide because it puts every insulin on one canvas. Look at that tall, skinny green spike. That is your rapid analog in fast, out fast, perfect melt-time cover. Regular is lower and broader. Now see that big rolling here in the middle? That is NPH in, and that fat peak is exactly why it causes nocturnal lows. And those two flat lines cruising along the bottom, glargine and digludic, that is the steady basal tone we are always chasing. One honest caveat: these curves are illustrative, not drawn to scale, so read the shapes, not the exact numbers. If you truly get this picture, insulin dosing suddenly starts to make intuitive sense. Screenshot this one. Seriously, pause the video and take the picture. This is your one-page pharmacokinetic cheat sheet, every class an example, and its onset, peak and duration, all in a row, rapid analogs up top, then ultra rapid, regular, MPH, and the long and ultra long basals. But the big picture takeaway is beautifully simple, and it is the mental model for everything ahead. Bolus insulins cover your meals and your corrections. Basal insulins hold your fasting glucose steady in between. That is it. Everything in dosing is just deciding how much bolus, how much basal, and when. Alright, with the pharmacology locked in, let's go make some numbers. This is the regimen of choice, so let's nail it. Basal bolus, also called multiple daily injections. One long-acting basal injection holds your fasting glucose down all day. Then a rapid-acting bolus at every meal, covering the carbs plus any correction. Why is this the winner? Because it is flexible and physiologic. It bends to how the patient actually eats, instead of forcing them to eat around their insulin. Both NICE and ADA prefer it over the old twice daily premixed approach. But here is the catch: it only works if the patient is educated. Pair it with structured training like DAF, so they can carb count and self-adjust. Empowered patients get the best numbers every single time. Alright, math time, but do not panic, it is actually clean. Start with total daily dose, roughly 0.4 to 0.6 units per kilo per day, and about half a unit per kilo is a typical starting point. Go lower, around 0.3 in the elderly. Split it 50-50, half basal, half spread across meals as bolus. Then 2 rules to memorize. The 500 rule: your carb ratio equals 500 divided by the total daily dose, that is grams of carb 1 unit covers. And the 1800 rule: your correction factor equals 1800 divided by the total daily dose for rapid insulin, use 1500 for regular. Correction dose is glucose minus target divided by that factor, and always subtract insulin on board. Clean little building blocks. Let's make it real with a 70 kilo adult. Total daily dose and not 0.5 times 70. That is 35 units a day. Half of that is basal, call it 17 or 18 units once daily. The other half is bolus, roughly 5 to 6 units per meal. Now the ratios. Carb ratio 500/35, about 1 unit for every 14 grams of carb. Correction factor 1800/35, so 1 unit drops glucose 50. Watch it in action. Per meal glucose 250, target 120. That is 250 minus 120 divided by 50, roughly 2.6 units of correction added on top of the meal bolus. Then subtract insulin on board and recheck. That right there is the whole workflow. Starting doses are just an educated guess. Titration is where you actually win. For routine tuning, adjust basal by 10 to 20% every 2 to 3 days based on fasting glucose, and tune meal boluses using the 2-hour post-meal reading. Get patients self-monitoring at least 4 times a day, or better yet on CGM, and revisit those ratios during the honeymoon phase because needs shift fast. Then the situational curveballs. Kidney impairment, drop the dose 20 to 50% as function falls. Liver disease, cut about 20 to 25%. Steroids, requirements can rocket to 1 unit per kilo or more. And moving from 4 to subcutaneous, reduce the calculated dose about 20% and overlap the basal. Adapt, do not set and forget. Now the adjuncts, the supporting cast that can genuinely help. First up, pramlintide, a synthetic version of amylin. Here is a fact people forget: amylin is co-secreted with insulin, so in type 1 you are deficient in that too, not just insulin. Pramlintide does 3 neat things. It suppresses glucagon, slows gastric emptying, and boosts satiety, which together flatten those post-meal spikes. You give it subcutaneously at mealtimes alongside your prandial insulin, starting at 15 micrograms and titrating up to 30 to 60. Critical safety point: cut your mealtime insulin by about half when you start, or you will cause severe hypos. The upside: lower post-meal glucose, and it is weight neutral or even weight loss. Main downside is nausea. SGLT2 inhibitors, interesting, powerful, and genuinely risky in type 1, so listen up. They lower glucose in a completely insulin-independent way by dumping glucose into the urine. That gives you lower A1C, weight loss, lower blood pressure, and better time in range. Sounds fantastic, right? Here is the catch, and it is a big one: glycemic DKA. These drugs can trigger ketoacidosis with normal or only slightly raised glucose, so it is easily missed. The number on the meter looks fine while the patient is crashing. That is exactly why they are not broadly approved as a type 1 adjunct. If you ever do use one, keep a very low threshold for ketone testing and drill the sick day rules hard. Okay, this one genuinely excites me. Teplizumab, the first drug that actually modifies the disease instead of just replacing insulin. It is an anti-CD3 monoclonal antibody that calms the autoreactive T cells and protects your remaining beta cells. FDA approved back in November 2022, given as a single 14-day 4-infusion course for age 8 and up. And the headline result: it delays progression from stage 2 to full-blown stage 3 type 1 by a median of about 2 to 3 years. That is 2 to 3 extra years insulin-free. A newer study showed better C-peptide preservation in recently diagnosed patients too, and NICE has recommended it for the NHS. This is exactly why we screen at-risk relatives now, because we can finally act on a positive result. Let's talk tech, starting with pumps and sensors. An insulin pump delivers continuous, rapid-acting insulin as programmable basal rates with user-directed boluses for meals and corrections. It gives you fine, flexible, physiologic dosing. You can even vary the basal by time of day. But one crucial warning, there is no long-acting depot in a pump, so if it fails, DKA can develop fast. Then continuous glucose monitoring, a tiny subcutaneous sensor reading interstitial glucose every few minutes, either real-time or intermittently scanned. ADA says offer CGM as early as possible, even at diagnosis. It cuts hypoglycemia, and the ambulatory glucose profile gives you a standard way to review the data. Pump plus CGM sets the stage for the real magic coming up next. And here is the real magic: automated insulin delivery, the hybrid closed loop. Take a CGM, a pump, and a smart control algorithm, and it auto-adjusts the basal insulin in real time based on glucose. It is called hybrid because the user still carb counts and gives me boluses. The loop handles the background. ADA now calls AID the standard of care for type 1, and that is a big statement. It improves time in range, cuts both highs and lows, and genuinely reduces diabetes distress. NICE, back in 2023, said offer it to all under 18s in pregnancy and to adults with A1C at or above 7.5% or disabling hypos. Look at that donut, over 70% in range. That is the goal we are all chasing. Targets, because you cannot hit what you do not aim at. ADA's headline numbers: A1C under 7% for many non-pregnant adults, time in range over 70%, and time below range under 4% with under 1% below 54. And here is a motivating fact: every extra 5% of time in range is clinically meaningful. But please individualize. Go tighter, under 6.5 if you can do it without hypos. Loosen up under 8 for limited life expectancy or lots of comorbidity. Check A1C or CGM metrics at least twice a year, every 3 months if not at goal. And never forget the DCCT lesson. Tight control early pays microvascular dividends for decades. That is metabolic memory. Let's put NICE and ADA side by side because you will be asked to compare them. The headline difference: NICE aims tighter at or below 48 millimoles per mole, that is 6.5%, while ADA uses under 7, individualized. NICE gives the granular glucose targets in millimoles per liter, fasting 5 to 7 per meal, 4 to 7, post-meal 5 to 9. ADA works in milligrams per deciliter. Both want frequent monitoring, at least 4 times a day, and both prefer basal bolus or AID. My one warning: watch the units. NICE is millimoles per liter, ADA is milligrams per deciliter, and mixing them up is a classic exam trap and a real-world danger. But both agree on the big idea: individualized, hypo-aware targets. Now, the emergency everyone fears: diabetic ketoacidosis. Recognize it by the triad. Hyperglycemia, glucose at or above 200, though remember, glycemic DKA can look deceptively normal. Ketosis, beta-hydroxybutyrate at or above 3 or urine ketones 2+, and acidosis, P at 7.3 or bicarbonate under 18 with a raised anion gap. Mechanistically, it is insulin deficiency plus a surge of counter-regulatory hormones, glucagon, catecholamines, cortisol, growth hormone, driving hyperglycemia, lipolysis, and ketogenesis, with osmotic diuresis stripping out fluid and electrolytes. Common triggers: new onset type 1 insulin omission, that is a huge one, infection, MI surgery, and do not forget SGLT2 inhibitors causing the eglycemic version. Spot it fast because the sooner you treat, the better they do. DKA management, let's make it a checklist you will never forget. Number 1, fluids first. 0.9% saline, 500 to 1000 mL an hour to start, and add dextrose once glucose falls to around 200 to 250. 2. Insulin for regular at 0.1 units per kilo per hour, and you keep it running until ketones are under 0.6 and the acidosis clears. 3. Potassium, and this is the one that catches people out. Make sure potassium is above 3.3 before you start insulin, because insulin drives it into cells. Replace when serum is 5 or below. 4. Bicarbonate is not routine. Only consider if pH is under 7. And 5. Transition, overlap subcutaneous, basal 1 to 2 hours before stopping the drip, and treat the precipitant. Flip side of the coin, hypoglycemia, and it can kill faster than hyperglycemia. 3 levels. Level 1, theolalio under Sanji. Level 2, clinically significant under 54. Level 3 is severe, any level where the patient needs someone else's help. The symptoms come in 2 flavors. Autonomic first, shaking, sweating, palpitations, hunger, anxiety, those are your early warnings. Then neuroglycopenic as the brain starves, confusion, odd behavior, seizures, loss of consciousness. Here is the danger. Recurrent lows cause hypoglycemia unawareness, where those warning signs get blunted, so patients crash without notice. Assess awareness at every review. And remember, in type 1, the glucagon counter-regulation is impaired, so the body's own rescue system is partly broken. So how do we treat it? If they are conscious, it is the rule of 15. 15 to 20 grams of fast-acting carb glucose tablets, juice, not chocolate. Recheck in 10 to 15 minutes. Still under 70. Repeat. Once they are back up, follow with a longer acting carb or snack so they do not dip again. But if they are severe, unconscious or unable to swallow, you cannot put anything in their mouth. That is when glucagon steps in. Injectable 1 mg IM or SC, half a milligram in kids, that is the one a family member can give, or nasal glucagon, 3 mg, no mixing, no needle brilliant for lay rescuers. It works in 10 to 15 minutes. Give carbs as soon as they can swallow. Teach every family this. Let's zoom out to the long game, chronic complications, and how we screen to catch them early. Microvascular first. Retinopathy, still a leading cause of new blindness in working age adults. Nephropathy, marching from albuminuria to chronic kidney disease, and neuropathy, both sensory-motor and autonomic. Then macrovascular, heart attacks, strokes, peripheral arterial disease, so manage blood pressure. Put them on statins, tackle smoking and weight. And the golden thread through all of it: intensive glucose control prevents or delays the lot. The screening schedule is your safety net: dilated eye exam at diagnosis, then yearly annual urine and HCFR, annual foot check, cardiovascular risk at every review, and do not forget to assess hypo-awareness annually too. Screening safe site, limbs and lives. 2 things to round out the clinical picture: special populations and sick day rules. Pregnancy or planning, tighter targets and great candidates for CGM and AID, children under 18 eligible for closed loop, weight-based carbs for treating loss, and teplizumab from age 18 stage 2. Older adults, loosen the A1C, aim under 8 and start lower, around 0.3 units per kilo. Kidney or liver impairment, drop the total dose 20 to 50%. Now the sick day rules, burn these in. Never ever stop insulin. Illness raises requirements, it does not lower them. Check ketones if unwell or persistently high. Keep hydration and carbs up. Monitor more often. Adjust doses. And rising ketones with vomiting. That is an urgent same-day review. Assume DKA until proven otherwise. Alright, let's bring it home. The 7 points to remember. 1. Type 1 is autoimmune, absolute insulin deficiency, and insulin is life-sustaining. 2. Basal bolus or AID is standard. Total daily dose around 0.4 to 0.6 units per kilo, about half basal. 3. The rules: 500 ratio, 1800 for rapid correction, 1500 for regular. 4. Targets AD. A under 7%, NISAT or below 6.5, aim for time in range over 70. 5. DKA, through its first, insulin 0.1 per kilo per hour, potassium above 3 to 3 before insulin. 6. Hypos, rule of 15, glucagon 1 mg injected or 3 mg nasal. And 7. The adjuncts, pramlintide, S. GLT2 inhibitors with that euglycemic decay, a warning, and teplizumab to delay onset. That is your complete masterclass. If it helped, like, subscribe, and I will see you in the next one.